ni hacer para bañarme bien, los platos. Pero ahora lo hago bien, y baño bien, y conmigo como 7, 10 bloques ahora, tranquilo.
Before
Before one. No, that's all.
Before I took captopril, I couldn't walk for any distance at all. I could just walk about a block before I became short of breath. I couldn't eat very well. As I said, I was losing weight. I couldn't even shower properly because I didn't have the strength. Now I can walk even 10 blocks before I feel any shortness of breath, and I can eat just about anything I want.
You see, now I go to Puerto Rico.
Well, about 2/3 of patients who have been started on captopril therapy will experience a relief of exertional dyspnea, a relief of symptoms of orthopnea. They will stop getting up at night with acute shortness of breath. They will be able to walk farther, their exercise tolerance will improve, and because of this, their activities of daily living will be enhanced because they'll be able to do much more than they were ever able to do before.
Clinicians from around the world gathered recently at the Residence Palace in Salzburg, Austria, to participate in symposia on the failing heart and worldwide clinical experience with captopril. Among the participants were Dr. Milton Packer of the Mount Sinai Medical Center in New York, Dr. Robert C. Tarazi of the Cleveland Clinic Foundation, Dr. Michel Comarchda of the PT Salpêtrière in Paris, Dr. Warren Walsh of the Prince Henry Hospital in Sydney, Australia, and Dr. Barry Kramer of the Veterans Administration Hospital in San Francisco. These physicians have all conducted clinical investigations of captopril in the therapy of heart failure.
Warren, one of the differences in our studies was that our patients were ambulatory and stable outpatients, whereas your patients were sicker patients with more advanced heart failure. And this gave us the luxury of enrolling our patients in a placebo-controlled randomized trial of captopril in heart failure.
Yes, Barry, we studied 10 patients with severe heart failure. 9 of them were New York Heart Association of Functional Class 4. They were patients who were in hospital and we were unable to discharge them because of their severe symptoms. And we studied them at rest with hemodynamic monitoring. We did an acute hemodynamic study with using 25 or 50 milligrams of captopril, and having determined the hemodynamic response, we followed them till discharge, and then after discharge we followed them at frequent intervals and then restudied as many patients as we could after 6 months of therapy of captopril. We did a similar study to the acute one with repeat catheterization, and we were able to show that the effects of captopril in our 10 patients was quite dramatic acutely, in that we were able to show an improvement in cardiac index and a fall in filling pressures of quite substantial proportions, and this seemed to correlate with the improved clinical status of the patients.
Mr. Rodriguez is a 69-year-old man who has a 5-year history of severe congestive heart failure due to a congestive cardiomyopathy, which was diagnosed several years prior to his last hospitalization. He was last hospitalized in July of 1981, at which time he had signs of severe biventricular failure. At that time, he underwent right heart catheterization and had a pulmonary capillary wedge pressure of 26 and a cardiac output of 3.4 liters per minute. He was started with an initial dose of 25 milligrams of captopril orally, which decreased his pulmonary capillary wedge pressure from 25 to 15 and increased his cardiac output from 3.5 to 4.2 liters per minute. He was maintained on Captopril 100 milligrams daily, and at the end of 72 hours of therapy, had a pulmonary capillary wedge pressure of 12 millimeters of mercury and a cardiac output of 4 liters per minute. Over the last 10 months, he has been on Captopril and has maintained excellent exercise tolerance. He can now walk 10 blocks without any shortness of breath, eats well, sleeps well, does precisely what he pleases, and has not been hospitalized for any signs of congestive heart failure for the last 10 months. He has had no adverse reactions from Captopril therapy.
The type of patient that we looked at was a little bit different than yours. The majority of our patients were New York Heart Association functional class 3, and we had an occasional functional class 2 patient. And our study protocol was somewhat similar to yours. We brought our patients in. They tended to be very stable. They were ambulatory patients. They underwent an elective right heart catheterization. And then, much as you did, we looked at the acute resting hemodynamic effects of Captopril and found very similar changes. They had a 25% increase in cardiac index, 42% decrease in left ventricular filling pressure, and responded much the same as your sicker patients. Our patients were treated for 3 months after their acute hemodynamic studies in hospital. The patients were randomized either to Captopril or to placebo, and then the drug dosage was titrated to a maximum of 100 milligrams 3 times daily. They then were continued on this dosage for the 3-month interval, brought back to hospital, and underwent an elective recatheterization to look at the long-term hemodynamic changes. In looking at 3 measurements of exercise capacity, the duration of exercise on the upright bicycle, the maximum workload achieved, the maximum oxygen consumption, all 3 measurements increase on chronic Captopril therapy, and this matches an improvement in their exercise hemodynamic measurements.
We evaluated the effects of Captopril in a group of patients with severe congestive heart failure. These patients were in class 3 or in class 4 of the New York Heart Association, and the etiology of heart failure was due either to a congestive cardiomyopathy or to an ischemic heart disease. Acutely, we observed a marked increase in cardiac output and cardiac index, a decrease in capillary wedge pressure, and a fall in systemic vascular resistances. Paradoxically, heart rate did not change significantly. I mean that no tachycardia occurred, although arterial pressure fell. We found a significant reduction in both left ventricular and diastolic and systolic diameters, and an increase in fractional shortening. Concomitantly, left ventricular ejection time increased and pre-ejection period was reduced. This indicates, obviously, an improvement in cardiac performance.
I think one of the advantages of Captopril is the first vasoactive drug available which specifically inhibits the renin-angiotensin-aldosterone system. And in patients with chronic heart failure and a considerable amount of fluid retention, there's no question that the high aldosterone levels is a very important factor in that fluid retention and in the congestive symptoms of the patient. This drug allows us to substantially reduce the aldosterone levels, and I've no doubt helps alleviate the fluid retention problem.
And the advantage of Captopril is that it really has a balanced effect, causing both arteriolar dilatation and also apparently an increase in venous capacitance, which has not yet been explained by the drug's reputed mechanism of action by inhibiting angiotensin-converting enzyme.
Because of the role of angiotensin in stimulating production of aldosterone, Captopril will decrease circulating aldosterone levels. And because of its effects as an aldosterone antagonist, it will act as a diuretic as well as a vasodilator. But however, it acts as a very specific type of diuretic. It acts as a potassium-sparing diuretic because of its anti-aldosterone effects.
Did you have any problems with hypotension in your patients, symptomatic hypotension?
We didn't have a problem with symptomatic hypotension, but as you found, we found that there is a first dose hypotensive effect with Captopril, and there can be profound drops in blood pressure with the patients. But surprisingly, the patients tolerate the drop in blood pressure very well, And in generally, the major complaint with people whose mean arterial pressure fell into the low 60s was lightheadedness on standing up. And that was an acute finding. If you let them stand in position for several moments, that would go away.
One of the concerns of any vasodilator drug is the fact that a vasodilator agent, by definition, will decrease systemic blood pressure. And when we use it in a patient with chronic heart failure who has a normal blood pressure to begin with, then we are particularly concerned about dropping systemic pressures. What is interesting about captopril is that it does drop systemic blood pressure, and in some cases drops systemic blood pressure quite dramatically. However, patients seem to tolerate this drop in blood pressure much better than they do with other vasodilator drugs. It is not uncommon for us to see patients in whom captopril produces a 20 or 30 millimeter drop in blood pressure to levels which are considerably below 90 millimeters systolic. And yet they feel fine, they're able to exercise more, their shortness of breath is improved, and they do not experience symptoms of a cerebral hyperperfusion. They do not develop syncope, they do not develop dizziness, and for reasons that we're not exactly certain, they walk around with blood pressures of 60 to 70 systolic without too many problems at all.
The usual starting dose of captopril is 25 milligrams TID. A starting dose of 6.25 or 12.5 milligrams TID may minimize a transient hypotensive effect. In the following discussion, Dr. Packer reports on a clinical investigation in which higher than usual doses were employed.
We used 2 dose levels of captopril in our studies. In patients with normal renal function, we used a dose of 100 milligrams 3 times a day, a total of 300 milligrams orally. In patients with creatinines greater than 2.5, we used a dose of 25 milligrams 3 times a day, a total of 75 milligrams daily. I should point out, however, that the dose-response curve of captopril is relatively flat, and patients respond to a dose of 25 milligrams in a fashion which is very similar to the effects of 100 milligrams of the drug.
One of the advantages of captopril is that it's a very well tolerated drug, and we have not had any significant side effects with the drug. The only problems that we've noted is occasional symptomatic hypotension, which we have alleviated by reducing the dose.
Captopril was very well tolerated. One of the major problems we've had with vasodilator drugs in general has been a high incidence of adverse reactions, and this was particularly true with a drug such as hydralazine, which, although produced acute hemodynamic effects in many patients, was not very well tolerated. Captopril, on the other hand, appeared to produce very few adverse reactions.
Side effects were very rare in our patients. We noticed only 1 transient proteinuria and 2 hypereosinophilia, which spontaneously regressed without changing the therapy. We did not notice either skin rash or anemia, and we didn't find out severe partial hypotension.
At our late study, we were able to show that the acute hemodynamic benefit we showed initially was maintained, which I think is interesting in that with some other drugs, tachyphylaxis has been a problem. So we were somewhat surprised to find that the magnitude of the beneficial acute effect was still there at the late study.
Warren, we found, as you did, that the acute hemodynamic effects of captopril are sustained during chronic therapy. What we added to your study was the exercise hemodynamic changes both acutely and then after 3 months of therapy. And we found, as with the resting effects, that the exercise hemodynamic changes are maintained as long as the patient continues on their captopril therapy.
We have performed invasive measurements both initially and after several weeks to months of therapy in approximately 65 patients who have received varying doses of captopril. And we have found tolerance not to be a problem with the drug that the initial effects are sustained long-term, and that over 2/3 of patients seem to have sustained clinical benefit, meaningful clinical benefit, in the sense that there is a distinct change in their symptoms and a distinct change in the limitations of their lifestyle.
Barry, what do you think is the place of captopril in patients with congestive heart failure?
I think in functional class 3 and functional class 4 patients, captopril should be considered a standard part of therapy in these patients and should be used concurrently with digoxin and diuretics in all these patients. The question of therapy in patients with milder heart failure who are functional class 2 patients, I still think is an open question.
I think, we've all been impressed with the fact that cardiac failure appears to be a progressive disease, so it would be really desirable if we could perhaps intervene early and change the natural history. We have no idea at this stage, but perhaps vasodilator therapy may be one approach that might alter this. There's certainly some experimental evidence that this may be possible.
Although I expect that as we know more about the drug and that as some tendency in some centers will develop of not using digitalis or diuretic for whatever reason in patients with mild heart failure, there might be some growing tendency to utilize captopril earlier rather than later in the course of the treatment of heart failure.
We didn't have any significant problems with neutropenia or proteinuria that were troublesome at all, forced us to consider discontinuing the drug. So that was very well tolerated by our patients, and they all felt well. They felt very contented, and they were a very easy and cooperative group of patients to study. They were very willing to do everything we wanted them to do.
The problem with the use of vasodilator drugs in chronic heart failure have not been a problem with accepting the principle of vasodilator therapy, but finding a drug that produced beneficial effects without producing major adverse reactions. And although a number of drugs seem to at first fulfill that requirement, none really, until the appearance of captopril and the use of captopril, appeared to fulfill that need. And I think that now that we have a vasodilator that actually acts in a manner which is expected and consistent with the hemodynamic principles, I think we will become much more comfortable with the use of vasodilator therapy and begin to use it earlier and earlier in patients with severe left ventricular dysfunction.
You see, now I go to Puerto Rico.